A very warm good evening, everyone, and welcome to today's webinar on uncontrolled to difficult to control asthma. I'm Dr. Keerat Sibia, consultant pulmonologist from Ludhiana, Punjab, and I couldn't be more excited for today's webinar for two special reasons. First, the GINA 2024 guidelines are just out, and there's so much of buzz and excitement about that. And today we have none other than our beloved, our very own Dr. N.H. Krishna sir, who is the founder, trustee, and chairman of CCI. Even though sir is very humble and he doesn't like it when we talk too much about what all he's done for us young pulmonologists in India. But out of gratitude, I want to say that, he has done so much for pulmonology, especially asthma. He has conducted 18 years continuously annual asthma camps pre COVID. And I can't think of anyone who's more befitting to preside today's webinar.
Without further ado, I would start my brief talk on difficult to treat asthma. So let me begin by reiterating the definition of asthma, which we have so memorized by heart. Asthma is a heterogeneous disease usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. Airflow limitation may later become persistent. The recent global burden of diseases estimate showed that the total burden of asthma in India was nearly 34 million, and it accounts for nearly 13% of the global burden. It also attributed that there were 13.2 per thousand deaths due to asthma in India, 1.9% of disability adjusted life years, DALYs, in the Indian population. India has 3 times higher mortality and more than 2 times higher DALYs compared to the global average asthma burden. We are second only to China in terms of disease burden, but unfortunately, mortality is almost 4 times higher than China. The GAN study was one of its kind and most enlightening in terms of bringing to our notice that 82% of patients with early symptoms remain undiagnosed. 70% of those patients who have severe asthma remain untreated as they don't visit doctors. And 2.5% of diagnosed patients are using only 2.5% of diagnosed patients are using daily inhalation therapy. When we think in terms of difficult to treat asthma or severe asthma, that is uncontrolled asthma, so let us look at the data. So let us look at the patients or the number of patients who are at GINA step 4 to 5 of treatment. So epidemiological data showed that there were about 24% who were at GINA step 4 to 5 treatment. And there was 3.7% with severe asthma. That is despite being at GINA 4 to 5 treatment, and despite in good all possible interventions with with technique and therapy, there was still persistent poor symptom control. So when we talk of uncontrolled asthma and we look at the unmet needs in the management of patient, we need to first understand what we mean when we talk about uncontrolled asthma. Uncontrolled asthma is defined as asthma with poor symptom control or frequent exacerbations. Poor symptom control meaning frequent symptoms or reliever use, activity limited by asthma, frequent night awakenings due to asthma. And frequent exacerbations refer to more than 2 per year, or those requiring oral corticosteroids, or serious exacerbations requiring hospitalization. Difficult to treat asthma is essentially asthma that is uncontrolled despite medium or high dose inhaled corticosteroids with a second controller, or maintenance oral corticosteroids, or that requires such treatment to maintain good symptom control and to reduce the risk of exacerbations. In most cases, difficult to treat asthma could be because of modifiable risk factors like incorrect inhaler technique, poor adherence, smoking, or comorbidities, or incorrect diagnosis. So let us look at the latest GINA 2024 asthma management protocol. So we have the track 1 and track 2. Basically, track 1 continues to be essentially the smart therapy. That is, we are using ICS formoterol as both as a reliever and as a maintenance. You can see at step 1 and 2, we have ICS formoterol only on SOS or as needed basis. And we have step 3 where we have low dose maintenance ICS formoterol, and step 5 we have medium dose ICS formoterol, and on step 5 we add on a LAMA, or we further assess for phenotypes because asthma is essentially still uncontrolled, or we consider high dose maintenance ICS formoterol, or we consider adding low dose oral corticosteroids. So this is where we are when we are at step 5. And alternatively, if we look at the track 2, here we have ICS SABA as a reliever or on SOS basis. At step 2, we have low dose maintenance ICS. At step 3, we have low dose maintenance ICS plus LABA. And at step 4, we have medium or high dose maintenance ICS LABA. And at step 5, we add on a LAMA. And again, we look for further assessment in terms of phenotype assessment and looking to add maybe a leukotriene receptor antagonist or azithromycin or oral corticosteroid and so on. So how do we differentiate between difficult to treat asthma or severe asthma? Difficult to treat asthma is asthma that is uncontrolled despite prescribing medium or high dose ICS LABA, or that requires high dose ICS LABA treatment to maintain good symptom control and reduce exacerbations. It does not mean a difficult patient. Severe asthma, on the other hand, is that which remains uncontrolled despite adherence with optimized high dose ICS LABA therapy and treatment of contributory factors, or that worsens when high dose treatment is decreased. Approximately 3 to 10% of people with asthma have severe asthma. So let us look at the protocol of dealing with or further assessing patients with difficult to treat asthma. So first of all, we look to confirm the diagnosis, to reassess whether we are missing any diagnosis, if there's any comorbidity, or is there an alternate diagnosis to asthma which we could have overlooked. Then we look for factors which could be contributing to symptoms, exacerbation, and poor quality of life, like incorrect inhaler technique, suboptimal adherence, comorbidities such as obesity, GERD, chronic rhinosinusitis, or OSA. We look at the modifiable risk factors and triggers at home or work, including smoking, environmental exposures, allergen exposure, or medications such as beta blockers or NSAIDs. We look for overuse of SABA relievers, medication side effects, and any underlying anxiety or depression or social difficulties. Then we move on and we move on to the next step, that is we optimize treatment. We check if we check and correct inhaler technique and adherence. We can upscale medication. We look for asthma education. Asthma education, the motto for GINA 2024, the World Asthma Day, is education empowers. Information is the key. And this holds true not only for us as physicians who need to update ourselves and upgrade our knowledge, but also for our patients Look at the importance of having a written asthma control protocol for patients. Information is empowering, information is the key, and knowledge is empowering. So we must empower our patients. So focus on asthma education, treat comorbidities and modifiable risk factors, consider non-biological add-on therapies, consider non-clinical interventions. Consider a trial of high-dose ICS if not previously used. At every visit, we need to assess and correct our patients' inhaler technique and encourage them for good compliance. Next, we need to move on and rule out asthma mimics and masqueraders like overlapping airway disorders, for example, COPD, bronchiectasis, cystic fibrosis, chronic upper airway cough syndrome. We need to look for anatomical airway obstruction like some inhaled foreign body, perhaps laryngospasm, laryngeal edema, laryngotracheobronchomalacia, benign or malignant endobronchial tumors or endobronchial tuberculosis, factitious asthma due to vocal cord dysfunction. And then we need to look for other conditions which could be associated with wheezing, such as hyperventilation or dysfunctional breathing, congestive cardiac failure leading to cardiac asthma, medication related cough, pulmonary embolism, or Loeffler syndrome. So, in the end, I would like everyone to focus on this slide while we elaborate on this later during our discussion. And I think the latest addition is the stress on RSV infection prevention in the GINA 2024 guidelines, and also focus on pertussis prevention, while we are all familiar with the influenza, pneumococcal, and herpes vaccination. Thank you.
You are muted, Keerat.
I would now like to welcome our esteemed faculty for the day. I would like to begin by welcoming our very own and beloved Dr. VKC, Dr. Vijay Kumar Chennamchetty, sir. Sir is Senior Consultant, Interventional Pulmonologist at Jubilee Hills, Hyderabad. And I refer to Sir more often than not for guidance. And I thank you for that, sir. Thank you for always guiding us. And may I mention, sir, is the academic director for CCI webinars. Next, I would like to welcome none other than everybody's favorite, Dr. Atri Gangopadhyay. Dr. Atri is a very renowned pulmonologist from Ranchi. He's the pioneer in oscillometry in the state of Jharkhand. And he's one person who's always there to lend a helping hand and a kind ear to anyone in CCI, including myself. Thank you, Dr. Atri, for always being so kind. And he's the official spokesperson for CCI because of his extraordinary communication skills. And he's also the East Zone Governor of CCI. Welcome, Dr. Atri. Next, I would like to welcome Dr. Dhaval Prajapati, who's joining us from Karamsad, Gujarat. Dr. Dhaval has special interest in critical care and is assistant professor at Sri Krishna Hospital, Karamsad, Gujarat. Welcome, Dr. Dhaval. Very nice to have you here with us today. I move on to welcome Dr. Next, I would like to welcome, we have Dr. Kumar Mehta with us. Dr. Kumar, I'd like to welcome you, sir. Dr. Kumar is a transplant pulmonologist. He has special interest in allergy. And Dr. Kumar is practicing intervention at Lucknow, at Ahmedabad. So welcome, Dr. Mehta. I think everyone should unmute themselves. Next, I would like to welcome Dr. Utkarsh Srivastav. Dr. Utkarsh Srivastav is from Lucknow and practicing at RML Institute of Medical Sciences. And Dr. Utkarsh has special interest in allergy practice and asthma practice. Welcome, sir. Welcome very much. So I would like to start today's Q&A with Dr. Atri. Dr. Atri, what is your opinion about asthma incidence? Is it increasing or is it decreasing, and why so?
Thank you, Chess Council of India, for the opportunity to give me part of a webinar on World Asthma Week, and that also with star-studded panel. I would comment on the beautiful presentation that you have made and the figures which you brought. The figures open a very big story. So I would want to extrapolate those figures into something which people can understand easily. What if I tell you that 1 out of every 5 kindergarten children is going to get asthma? 1 out of every 7 primary school student is going to get asthma. 1 out of every 10 engineering or medical aspirant in India is going to get asthma. 1 out of every 15 new job seeker is going to get asthma. This is how high the incidence of asthma has increased. Certain factors which I contribute. Earlier, asthma was thought to be hereditary, that if someone in the family had it, you are going to have it. Nowadays, other than hereditary, there are certain factors. One, these frequent viral outbreaks that are occurring when the body is recovering from the viral infection, the type of inflammation going in the body is pushing us towards asthma. Second, air pollution is a very big price we are paying for development, but the children being exposed to air pollution is driving them towards asthma. Third, overcrowding. The number of people squashed per square feet or per square kilometer in our urban areas or in our offices or institutes are so much that this overcrowding leading to lack of ventilation is perhaps increasing incidence of asthma. Fourth, I forget when was the last time I found a candle filter in the market. When we were kids, it was either a hand pump, it was a well, or it was candle filters. But nowadays, we are forced to drink processed water, which is pushing us away from nature, from the much celebrated hygiene hypothesis, which is creating increased incidence of asthma. Over to the panel.
Wow, wonderfully elucidated, Dr. Atri. I didn't think that you would even come to water filters in our house. So I agree with you. I couldn't agree anymore that air pollution, we are talking about it, but something needs to be done high time, and it's a very serious concern. Next, I would like to come to Dr. Utkarsh, sir. Dr. Utkarsh, how do you assess asthma severity in a patient?
Please unmute.
Yeah, please unmute yourself, Dr. Utkarsh.
Thank you, first of all, to Chester Council of India for giving me opportunity to speak on this platform. Basically, we are assessing on the day and night symptoms of the patients. If their symptoms are increasing and even they are taking inhalers and other nebulization form, but they are still persisting had symptoms like night walking symptoms are there, their dyspnea is increasing, they have frequent viral infections are there. So I think severity of not taking the inhaler properly technique. These are the things I think that this is regarding leading to the severity of the patients, to severity of the asthma increasing day by day.
So, like you just mentioned, that we look at the symptoms, we look at the frequency of symptoms. That is correct. But
Activations are there.
And exacerbations, certainly. However, to assess asthma severity and to label as mild asthma or severe asthma, what Gina is recommending is that we should look at it in a retrospective manner. That is, we cannot say that somebody has a mild asthma, because even somebody who's using SOS basis reliever may have a very serious exacerbation, which may not be mild. So, uh, assessing severity is going to be retrospective based on how the past year or the past few months have been, and how much was the requirement, the medication requirement, to control the symptoms. Thank you very much. And next, I would like to come to Dr. Dhaval. Dr. Dhaval, okay. So, how would you differentiate between difficult asthma, difficult to treat asthma, and severe asthma?
Yes. First of all, I would like to thank you, CCA, for giving me opportunity for this platform. Yes, there is a much difference between the difficult to treat and severe asthma, and we have to uh, uh, diagnose this proper way, because the management would be different in both the ways. So if we say difficult to treat, means whenever the patient is having asthma and the symptoms are uncontrolled even after prescribing the medium or high dose therapy with the inclusion of the inhaled corticosteroids and the LABA, I mean particularly the formoterol, and even with the treatment, the symptoms are uncontrolled. And when you decrease the high dose of this ICS LABA, even in a step down manner, and the symptoms are worsen up, then it is called as the difficult to treat asthma, because there are many modifiable factors, comorbidities, the techniques, inhaler techniques, adherence, the other psychosocial problems we have to consider in that, which are the modifiable factors. Whereas is severe asthma is whenever a patient is having the uncontrolled symptoms even after adherence to the high dose ICS LABA and the correction of the modifiable factors, or a patient is requiring high dose of ICS LABA, uh, uh, then if even if the dose is decreased, the some symptoms worsen up. So here there are two categories: difficult to treat, where we can modify on the patient side, on the management side, and in the severe asthma, where we can go ahead with the step up plan with the phenotyping and all we need to address them.
Very well said, Dr. Dhaval. So, when we think of patients who have difficult to treat asthma, these are typically patients who are at step 4 to 5 of GINA treatment plan, and they would require optimization of medication and optimization of other modifiable risk factors as well. And once we do that, we may be able to attain control, or these are the patients where decreasing medication leads to a lack of control, so the requirement of medication is very high. So wonderfully you've elucidated. And we are not talking about basics like how to diagnose asthma. This is something we all know. We've all grown up literally reading, FEV1, and we know those criterias. And now that even that PEFR, GINA 2024 is really stressing on the fact that a lot of specialists out there also do not have access to spirometry, PFT testing around the world. As we understand that GINA 2024 or GINA in general is not only for our country, but for pulmonologists and specialists and practitioners around the world. So they have even, other than FEV1 increase post bronchodilation by 12% and 200 ml, or they have added that they've laid stress that PEF should be measured, and pre and post bronchodilation, if there's an increase by 20%, that is also significant for diagnosis of asthma. But I would like to ask our oscillometry specialist, our pioneer, Dr. Atri. Dr. Atri, is there any role of oscillometry in asthma cases where we are dealing with difficult asthma?
Okay. First, I would want to make it clear that I would never give oscillometry in all patients of asthma. Number one. have your faith in spirometry. Spirometry is the most sacred thing for all pulmonologists, and perhaps that would have been the best invention to help all pulmonologists. But the moment we are going from the routine, and all of you here listening to our lecture would agree that difficult to treat asthma is increasing compared to simple cases of asthma. Oscillometry is helping me where spirometry is failing to show reversibility, and we are hit with a doubt that whether this is asthma or it is something else. Sometimes oscillometry can show reversibility where spirometry does not show reversibility, number one. Second, oscillometry shows something very clearly known as small airway predominant disease. Certain molecules or certain inhalers cannot be given in small airway predominant disease, which spirometry will never tell us. So if oscillometry is showing us a large airway predominant disease, you can give any inhaled corticosteroid and you can give breathe actuated device, DPI, MDI, anything. But the moment we come to small airway disease, then maybe certain DPI can help you, breathe actuated may not help you, or only MDI and spacer will help. Last week, myself, Dr. Jay, Dr. Dhaval, we were having a chat together at Anand, Gujarat, where we were discussing this thing only, that how oscillometry is helping us in phenotyping asthma patient to decide which inhaler fits which asthma patient. Other than these two parameters, the third place where oscillometry is helping us is sometimes there is overlap of interstitial lung disease with asthma. For example, rheumatoid ILD and asthma coexist. Chronic hypersensitivity pneumonitis and asthma coexist. Spirometry may not help us there, but oscillometry, there is a parameter which can also talk about the parenchyma or known as reactance. So you are getting obstruction, you are getting reversibility, but you are also getting some interstitial anomaly. And then you can suspect that no, here it is not pure asthma, there is something else also. So these are cases how oscillometry is increasingly becoming popular in management of difficult to treat asthma. And of course, a person who cannot perform spirometry despite our best endeavors will become a candidate for oscillometry also.
Wow, that was a learning point for me as well. We do have iOS at our system, at our setup, but this is not how I have looked at things. And certainly the small airway disease detection on oscillometry is very helpful. Next, I would like Dr. Chennamchetty sir to address that. How do we assess response in asthma treatment?
Thank you, Dr. Keerat, for that very, very important question. Before proceeding for that, let me thank CCA for having me here, and huge appreciations for your talk, because your talk, which was done in less than 10 minutes or close to 10 minutes, which was a wonderful talk. Okay. So congratulations, Keerat, for that brilliant presentation. And the moderation that you are doing is phenomenal. Okay. And let me come back to the question, how to assess the severity of asthma, right? That was the question, right?
Yes, sir. No,
Yeah.
my question is how to assess response in asthma treatment.
Oh,
Kind of
how to-
overlapping, but yes.
Right. See, basically, when we look in our clinical practice, it is very, very important. So first important to assess the response. So we have our own methods of assessment as a clinician, like how the patient is, whether he is able to, whatever the symptoms that he has presented in the last visit or the first visit. And then subsequently, you will see whether the symptomatic relief is there. That is wheezing, sneezing, breathlessness, cough. These are the main things which are the prime symptoms of the asthma. So if they are controlled or not. So anyhow, being specialists, and we need to have a lot of objective evidence rather than subjective evidence. So getting a spirometry and then see whether the obstruction has been relieved or not. That's one way of assessment. Daily monitoring of peak expiratory flow meter is one way of assessment. And more importantly, we should guide either if you have time, you can teach your patients about self-assessment by teaching the asthma control test, or you should ask your postgraduate or your physician assistant to train the patient about asthma control test. Generally, we assess in this asthma control test. So in the past 4 weeks or a month, okay, how you are doing in terms of breathlessness, general asthma symptoms as mentioned, usage of relievers, whether the usage of relievers, how many times the patient has used the reliever, we have to question. And then how about the activities of daily life, and whether he is comfortably performing his activities. If he is a office going person, if the patient is a school going child, okay, whether comfortably he is attending his duties or not is also very important. And then the overall general assessment is very, very important. That's how we educate the patient to um, let them understand their disease. This is very, very important. That's what the Xena 2024 says. Asthma education empowers. We have to give the enough training, being responsible pulmonologists of this country and the global, okay, pulmonologists. Okay, we should train them that they can identify, okay, when is the exacerbation happening, whether the asthma is under control or not. And coming to more objective assessment in the clinics, apart from spirometry, so we can do asthma control questionnaire. And GINA 2024 clearly stated that ACQ 5, that is with 5 questions, is very, very important. What are those 5 questions? One is nocturnal awakenings. Second is early morning symptoms. As soon as you wake up, how do you feel? And activity of daily life. How about your shortness of breath, and how about of your wheezing? So these are the 5 things which we have to monitor at the clinic level. And if you see the asthma control questionnaire 6, that is more importantly, the 6th question added here is how many times you have been used reliever in the past 1 month and or 1 week. And then the more objective evidence of in asthma control questionnaire 7, the 7th question added is the objective evidence of improvement or deterioration of spirometry values by measuring the FEV1. These are the various things, both asthma control test and asthma control questionnaire is what we need to use to monitor the disease in the clinic.
Very, very well elaborated, sir. Thank you for the special stress emphasis that you have laid down on explaining ACQ. And I would like to urge everybody who's watching us that we should actually add ACQ to our practice. ACQ 5 is okay for for the basic or the first patient visit, but subsequently using ACQ 6 or 7 and making sure the patient has a copy of that. The patient should diary it so that when the patient realizes, okay, I will be asked these questions at the end of 1 month or at my next visit. So they also note down their trend of 2 things patients should have. I think one is a written asthma plan in case of exacerbation. And second is noting in their diary, they should note down their, their extra reliever usage, how they are having to, have that extra medication that should be documented. Otherwise, patients a lot of time may be in denial that they're doing okay. Next, I would like to ask Dr. some wisdom from Dr. Mehta. Dr. Jay Kumar, sir, what is the current status of reliever medication in asthma? Dr. Jay? Is your internet hung up? Hello?
Yeah, we can see him now. His internet was gone. You repeat him once again.
Yeah, it's gone out. Yeah, it's back again.
So
Dr. Jay?
I think this is a very important question because in Hello.
Yes, yes, we can hear you now.
Okay, ma'am. Thank you so much.
Yes, we can hear you now.
Traditional teaching. Okay. In traditional teaching, reliever medications means using of a beta 2 agonist or ipratropium. These are generally categorized as bronchodilator medications. But with 2019 GINA guidelines, they have introduced one more term called anti-inflammatory reliever. And from there onwards, we have now two tracks, track 1 and track 2. With the platform of CCI, I would like to highlight this reliever concept to most of our patients, through the pulmonologist to most of our patients. So initially, we had two types of inhalers, a blue one and a red one, which we used to teach them that this blue one, you need to take it whenever there are symptoms of cough, breathing difficulty, wheezing or chest tightness. And this has to be taken as need basis. And then another one, which is known as preventer or controller, it has to be given regularly. Now, what the meta-analysis and the randomized control trials show is that if we use inhaled corticosteroids combining with the formoterol molecule, that is ICS formoterol, which is known as anti-inflammatory reliever, there is a more than 60% chance of decrease in severe exacerbations, as well as more than 60% chances in reduction in hospitalization. When it comes to efficacy, it doesn't make a difference if you are giving patient in step 1 and 2, whether you are using or giving budesonide daily or whether you are giving ICS formoterol as need basis after 1 year, there is no such difference between the trough FEV1 level. And hence, from 2019 onwards, we have now decreased in use of reliever, that is a SABA only reliever. So now there are two types of relievers. One is a SABA reliever and second is an anti-inflammatory reliever. So now there are two tracks in GINA. Track 1 is preferred anti-inflammatory relievers in all stages, whether from step 1 to step 5. It is preferentially having more efficacy in step 1 and 2. You rightly stated, ma'am, that most of the exacerbation, while assessing the frequency, while assessing the symptom control, 26% of deaths may happen even in mild asthmatic patient. So using anti-inflammatory reliever, that is ICS formoterol containing reliever, will help reduction in this severity and hospitalization and ultimately to the patient death or asthmatic death. Recently, we have been termed as asthma capital of world. Like we are constituting only 13 to 15% of cases, but 46% asthma deaths happening in India, where it has been linked of reduced, like very much less use of inhaled corticosteroids. The asthma deaths are straight related to that. So now, when we talk about the reliever treatment, first and foremost, we need to now segregate the SABA only reliever and anti-inflammatory reliever. GINA clearly gives advantage to anti-inflammatory reliever. If some person wants to give SABA only reliever, then it has to be stressed to the patient that whenever they are taking blue inhaler, they also have to take a budesonide in step 1 and step 2 treatment. So I think I made my stance very clear that nowadays we are going forwards to anti-inflammatory reliever, that is ICS formoterol containing reliever, and SABA only reliever have no place in current asthma management.
Very, very beautifully.
May I just add a very quick point, Dr. Keerat? Just add a quick point. Maybe in future, SABA only reliever shall be used during reversibility testing, not for clinical purpose. Maybe.
Maybe. And actually, I would like to take this further. So, Dr. Chennam, GINA has recommended against SABA only treatment since 2019. Why is it so? Dr. J also really elaborated on the fact that they don't encourage SABA, but GINA 2024 is clearly advising against it, using only SABA treatment. Please unmute, sir.
So, Keerat, that was, if I want to say one most important question of today's discussion is, if we can nail the information of this person to the GP level and family physician level, then our job is done. It's such a brilliant question. So what I want to tell a simple analogy. When we are rowing a boat, right? So there are two persons, on right side one, left side one. So imagine if we are rowing a boat, one person is lazy and then he is not rowing the boat. What happens? So boat will not go forward. Instead, boat will turn in circles and circles and circles, and will be not going anywhere at all. Okay. So the same analogy here is in management of asthma. So acute asthma, using a reliever, as Jay beautifully said. So when we are using reliever as a Saba, what is happening is it's the only one person rowing the boat, the other person sitting idle, and the disease will be there only. It may give a movement as a perception, but you are not moving forward at all. You're not getting better. Similarly, if we add anti-inflammatory reliever therapy, whether in terms of MAT or in terms of Saba plus budesonide combination, so what happens is there gets the equilibrium. You will get the adequate bronchodilation and you are getting the anti-inflammatory therapy as well. So what we need to understand is when we use the blue inhaler or reliever as a Saba alone, the over usage of this inhaler leading to marked inflammation. We are not controlling the inflammation, only bronchodilation we are targeting. Thereby, this leads to more amount of exacerbation. And this also leads to the poor adherence to inhaled corticosteroids, wherein the perception that our bronchodilation is happening, symptom control is happening, and we will neglect the usage of inhaled corticosteroids. That's why maintenance and reliever therapy or anti-inflammatory reliever therapy has made into practice since 2019. And other important thing is, since the anti-inflammation is not controlled, particularly during exertion or exercise-induced bronchoconstriction will be more often we see in these patients. And what the GINA says, various studies says is, those patients who use more than 3 canisters in entire 12 months time or entire 1 year, they tend to develop more amount of hospitalizations, more amount of exacerbations, and more amount of severe exacerbations, which lead to more amount of mortality. So that's why the blue is, as Atri said, as Dr. Jay said, it should be thrown out into the dustbin except for usage in bronchodilator reversibility testing. And GINA has made it for the past 5 years very clear of blue should not be or Saba should not be used alone.
Thank you, sir. You are, the way you've explained it, you're right. It is fundamental to revolutionizing the way asthma is treated. Because as we have better understanding of how these medications are working and why we don't want to use Saba alone, only that can be a deterrent to prescribing Saba alone. May I also add that GINA 2024 has further added information, as in it's further added evidence that patients who were prescribed maintenance in inhaled corticosteroids with reliever Saba, their adherence to inhaled corticosteroids was on the lower side. And that also resulted in more exacerbation. So they say that using Saba alone has to be totally phased out. It can be Saba ICS, but it cannot be Saba alone. So this is the GINA 2024 advisory. Thank you for...
Just to add one more important point here. Okay. Using the maintenance and reliever therapy as a single inhaler will cause, as per the GINA 2024, definitely it is going to decrease the exacerbation and decrease the hospitalization. Second point, decrease mortality by almost 65%. That is pretty good. So any mortality reduction by around 5%, 10% itself is a great achievement. But here, not using the reliever as SABA at all and using anti-inflammatory reliever therapy will cause 65% decrease in exacerbation, hospitalization, and mortality. So that is a key point that we have to nail to our entire doctors fraternity across India.
Thank you, sir. Thank you. With the GINA guidelines, GINA 2024 being like recently dropped, I think not everybody has read in that much detail as you have, and it's thank you for teaching us. I read it, but this point even I have missed. And sir, I would like to thank you for your compliments on my talk, and I would like to acknowledge that it was possible only with guidance from Dr. Krishna and help from Dr. Ravi Dosi. So I thank them and I acknowledge their help. Next, I would like to come to Dr. Utkarsh Srivastav. Dr. Utkarsh, we've been talking about reliever therapy, and we've talked about track 1 therapy, track 1 in GINA protocol of asthma management. And so we've talked about formoterol and budesonide. I would like you to answer and address that what is the ceiling dose for formoterol budesonide when we are using it as MART therapy, that is maintenance and reliever therapy, as in track 1?
Basically, MART is a maintenance and reliever therapy. We are using DPI. First of all, DPI budesonide, which is the power of 100 is to DPI, which is power of 200 MCQ to 6. We can use up to 12 inhalations per day. Whereas we are using meter dose inhaler, which is the power there of 200.
Oh, you need to unmute yourself, Dr. Utkarsh. Yes, please carry on.
Whereas when we are using the meter dose inhaler, which power of 200 to 6 MCQ, we can maximum dose which are recommended by the GINA new guidelines, which is 12 inhalation per day, and whereas in dexamethasone and formoterol, which is used 12 inhalation with the power of 100 to 6.
So you're absolutely correct. Basically, the formoterol dose in beclomethasone combination or even combination with budesonide, in both the cases, the formoterol dose is 6 microgram. So the ceiling dose for formoterol is 72 microgram in a per day or per 24 hours. So that limits the number of inhalations to 12 per day for both formoterol budesonide and formoterol beclomethasone. So next, I would like to ask you, Dr. Utkarsh, can we add ICS formoterol as a reliever with other ICS LABA maintenance therapy?
Yes, we can add.
Can we do that? Dr. J,
yes,
can we do that? If someone, I think Dr. J's video has internet is slow again. So basically, my question is open to the house. That
Here what it is that here we are basically talking about currently IPL is going on in India. Everyone is watching IPL cricket. So we need someone who is batting very fast from the first over itself, but who can bat all the 20 overs not out. Means fast onset of action, but long duration of action. So formoterol is a very beautiful, unique molecule. Its action starts within seconds to minutes, and its action lasts as long as 12 hours. So suppose someone is comfortable on, let's say, salmeterol fluticasone, or let's say monotherapy of beclomethasone or a monotherapy of mometasone. This person or someone with vilanterol fluticasone, this person also for reliever purpose, we can give this combination of formoterol ICS.
So yes, Dr. Atri, this is what has been the notion that was, that was gently in GINA 2023, they discussed about this, they touched upon this concern, but they did not give any clear recommendation. But in GINA 2024, they have advised that it is better to not use, ICS formoterol as an add-on when you're using any other ICS LABA, because they say that there's an increased risk of adverse effects, which are still under, this is still under study. But from what I understand, that it is to be discouraged. What is your take on this, Dr. Chennan?
So basically, as Atri clearly mentioned, so if you see, coming back to the question, okay, of using this, what do you call, MART, maintenance and reliever therapy. So it is like the match that has happened yesterday with the SRH. What has happened? Okay, our Travis Head, I believe, and then Sharmaji, both together, they have finished entire entire game in 9 overs. Right, Atri? Correct me if I'm wrong. Right. So, correct? Am I correct? Right.
Yes, yes.
So they've chased close to around 150 run, 170 runs or something, and that's what they are fastly. They completed I think in 12 balls, 50 runs kind of thing. So fast action is very, very important, and also long action is very, very important. So maintenance and reliever therapy so makes sense. So with the formoterol based combination only. Earlier, Solmetrol was being prescribed as a LABA of choice. I can say probably a decade back, but now no longer. For the past decade, the Solmetrol based combination is being used to treat asthma because its onset of action is like very late, delayed. So that's why formoterol is chosen. And then coming to steroids, the associated steroids we discuss in the further discussion. I hope I have answered, Keerat, for your question.
I think you've answered very well. I really like the way Dr. Atri referred to Formotrol as somebody who's an excellent, opening batsman and who we want, makes me think of Virat Kohli. And so I know I should maybe think of MS Dhoni because Dr. Atri is from Ranchi and Dhoni is from Ranchi. But sir, I like Virat Kohli. So, but yes, that is the reason Formotrol. It's quick action, long action. Is that it become the agent of choice, and also that's the reason we have a dedicated track 1 where it is to be used as MART therapy, and we don't have any other agent which we talk of in terms of using as MART therapy, as in the same thing as the same agent for reliever and maintenance. So this is only because Formotrol has that quick onset and long action. So from what we understand, GINA 2024 advises against using ICS Formotrol as a reliever if any other ICS LABA combination, like you mentioned, salmeterol, is being used as a maintenance therapy. So next, I would like to come to Dr. Dhaval. Dr. Dhaval.
Yeah.
We are talking about difficult asthma.
Right.
How would you like to approach a patient who continues to be uncontrolled at step 4 or 5 of GINA treatment protocol?
Right. So first of all, we have to confirm our diagnosis, whether it is difficult to treat asthma or whether we are dealing with a severe asthma. As we have mentioned earlier, that the difficult asthma is like wherever we give a patient is having uncontrolled symptoms, even after giving high dose of ICS, LABA, or maybe oral corticosteroids. And this high dose LABA ICS is always required to control the symptoms, right? So first of all, we need to diagnose the case, whether we are dealing purely with asthma or not. So not every dyspnea is asthma, not every cough is dyspnea, not every wheeze is asthma. So we have to rule out other comorbidities as well. Like dyspnea may have because of the COPD or cardiac disease, or maybe because of some obesity or OSA component. Like cough can be because of the bronchiectasis, can be because of the upper airway related problems, can be because of the postnasal drips or GERD, or maybe some drug related like ACE inhibitors. And again, like wheeze, again, it is not always because of the asthma. It can be because of the COPD or maybe upper airway anatomical problems. So first of all, we have to diagnose correctly whether we are dealing with asthma or not, as earlier mentioned, madam as well, regarding the how to diagnose asthma with the new guideline as well. And then we have to consider about the is there any other contributing factors which can lead to uncontrolled symptoms, right? Or maybe the risk of exacerbations, like proper technique, whether it is the patient is taking inhalers with the proper technique or not, or whether they are adherence to the inhalers or maybe other DPI or MDI, whether they are suboptimally adherence or not. Then we have to consider about the other comorbidities which also contributing to the symptoms, like GERD or COPD, cardiac disease, or obstructive airway disease, bronchiectasis, or maybe other upper airway related like sinusitis or allergic asthma, allergic components, rhinitis. Or there are some modifiable risk factors as well when the patient is continuous having exposure to the outdoor pollutions, air pollutions, indoor pollutions, some allergens. Then also the patient can be having the persistent symptoms. Sometimes there are risk factors when the patient is, as very well mentioned by regarding the SABA. Patient used to take SABA every time, and he is thinking that I am relieved with the symptoms with the SABA, and he used to continue with the SABA, and then end up with the airway limitations and further exacerbations. And sometimes some medications, particularly like AC inhibitors or NSAIDs, where patient is dealing with the some other comorbidities and taking these medications and having symptoms which are uncontrolled, even at this stage of 4 and 5 steps, where the high dose ICS LABA along with the some add-on therapies patient is taking. So we have to consider all these factors whenever we are dealing with the difficult to treat asthma patients. I hope I clear it.
Thank you for the elaboration, Dr. Prajal, Dr. Dhaval. And we have Dr. Krishna with us. Krishna sir has joined us. Sir, welcome. Welcome.
Namaste. Am I audible?
Yes, sir. You are wearing flag of India. I can see on your T-shirt. I'm not sure if it is what team it is. I mean, as far as I can think, it's Team India.
No. This is my alumni 10th standard reunion. There they gave me this T-shirt.
Okay.
So they had this. You can see that there is the flag of India, and this color is branded like the Karnataka's symbol. So that is it.
IPL watchers can be offended if I miss the right team. So I said I can't recognize, but yeah. So Team India is all I understand.
Team India is the only team because RCB is losing nowadays. So Team India is the only team for us.
No, this is the team Chitradurga.
Yeah. Where I studied my 10th standard.
Oh, right. Okay. Welcome, sir. We are so happy to have you here with us.
Thank you so much
for joining us.
Thank you so much. So, Keerat, wonderful as always. I have no words that how you moderate, and that pretty CCI logo fitting in here. Wow, proud. Actually, I'm very proud. So superb, fantastic panel. Like all my family only. Chennam is here, my dearest Tamudu. Atri is here, my fantastic Chota Bhai. Dhaval is here. Jai Kumar Mehta, Utkarsh, everybody. Thanks for coming to CCI. Now,
thank you, sir.
Now, I would like to take you all away from all these discussions. I'm a practitioner from the last 24 years. This is the 25th year. So I have crossed 24 years of practice. So I'll take you to those days regarding the treatment of asthma. There was a limited spectrum those days. salbutamol inhaler, salbutamol with DP didn't enter the market those days when I initiated my practice. Salbutamol inhaler, salbutamol with ipratropium salbutamol with budesonide, and later entered the market was salmeterol with fluticasone. So it could be like today drastic to hear to everybody see as that when we have to treat a patient of COPD, we have to use, if it is severe COPD, salbutamol, ipratropium bromide, salmeterol, fluticasone all together. That means two sector of MDIs. One is having salbutamol and ipratropium bromide, the other having salmeterol and fluticasone. But later then entered the formoterol and budesonide. Then later we had tiotropium bromide. All these things happened. But our initial days were very tough. Very tough, and the rise of the entire world global pulmonology from that level to this level is something to be hugely appreciated. Why? Because I still remember that I have witnessed everything. I will not put any company's name here. There was also something called an inhaler, which was neither salbutamol nor salmeterol. There was one inhaler which didn't contain any of these as a reliever also. So those were the days. And we used to give subcutaneous injection also for the same, with the same content of the inhaler. So there was only one nasal spray earlier which came into market, that was with budesonide. So from all that stage we have come here. But today, I would like to focus on few things. First and foremost, how formoterol came into existence, and salmeterol I consider was brutally murdered. Salmeterol, according to the guidelines of the US people, had few cardiac incidents, but we didn't face any of them in India, and nothing was documented in India beyond the US people. Salmeterol was murdered, I tell you. It was brutally murdered, but it still exists in the market. But formoterol took over everything. Now, a Canadian guideline tells us regarding the depressive effects of Montelukast, depression and psychosis, everything. But we haven't come across that in India. We still use Montelukast. So I would like to tell you that few areas are there. Like earlier, we used to always prefer salmeterol for COPD and formoterol for bronchial asthma. Those were the days. Now, it has evolved like anything. Now, coming to today's topic. And this topic was designed for the reason that this will come in two parts. One is uncontrollable to untreatable asthma, that is today's asthma, and severe asthma. Next week, my friend Raja is taking that. So we have left that severe asthma to him because he's a severe person. Now, coming to this today's topic, we have got 1038 logins now. Hats off to everyone here. Long live CCI. Hats off to everyone here. Now, before I talk about uncontrolled asthma, let me talk about poorly controlled asthma. See, there are two different things: poorly controlled, uncontrolled, difficult to treat, severe. So I'll not touch severe here because if I talk severe today, Raja has nothing to talk next week. So let's leave it. Now, uncontrolled asthma is someone, poorly controlled asthma is someone who is not under supervision. So no supervision from the doctor or the medical fraternity. He is doing whatever he wants. He is hearing from people. He is using the inhaler, which his family members are using for the same illness. And he's going to a chemist. He's taking bronchodilators. He's taking steroids whenever there is exacerbation. That is poorly controlled. Now coming to uncontrolled asthma. Uncontrolled asthma is where the dosage is inaccurate, the technique is inaccurate. So if the dosage and the technique is inaccurate, then it is a problem. You should behave like a police with the patient here. You should ask the patient to sit and ask, just demonstrate the inhalation technique to me, the way you do it at home. Sir, I open this, don't talk. Do you talk? When you do yourself at home, don't talk. Do it the way you do. So if you check the inhalation technique, it's wrong. And try to check the medicines. The people who cook daily in their house will not have left in their house any ration. So when this person has got this much of ration with him, the medication with him, that means that he's not taking them. If it doesn't get emptied, that means he's not taking it. So just observe whether a particular medicine, a DPI or MDA, we should have got over by this time for this month span or that month span. Is still left means he's not taking it. There is no other way of thinking that. So when you investigate the case, and when you should also investigate like a police, like whether even after taking the treatment for asthma, whether he's continuing to smoke, whether he lives in an area where there is a lot of parthenium around in his house, and you should also inquire his job where he's working. Are there fine particles in the air where he works? This is very important. So after all this, you decide and you treat this particular uncontrolled asthma. Now coming to difficult to treat asthma, we have to look for comorbidities. I will call it from head to beneath. Depression, mental tensions, sinusitis, allergic rhinitis, allergic pharyngitis. Go down here, let us go here. Thyroid, hyperthyroidism especially, goiter, that too retrosternal goiter, which is undiagnosed. Otherwise, if it is retrosternal, you cannot make it out immediately. Then you still go down, you have the heart, you have to rule out any cardiac illness. Let us go to the lungs. Let us see whether there is a bronchiectasis, which is not usually seen in a chest X-ray if it is tiny, or CT scan is required then. Obesity, OSA, all these things come into picture. So this is difficult to treat asthma, where you have to see the comorbidities other than the lungs and including the lungs, both of them. Now, here in difficult to treat asthma, you have to see the genotyping. In the genotype, Th2 dependent, non-Th2 dependent. Well, I would like to add something new here, telling everyone that the Th2 dependent asthma, earlier when there was no genotypes, I used to call always asthma as a hyperimmune disease to allergens. Hyperimmune disease to allergens. The extra unwanted Ig release in the body is the reason for everything. One allergen, one IgE, no problem. One allergen, 3 IgE or 5 IgE, huge problem. It's like there is a huge political gathering in your city, and your city's population is, example, 1 lakh, but that gathering attended by 2 lakh people. So those people come to your city. After they finish the political rally or procession, they go throw the bottles everywhere, throw the plastic everywhere. They rush into every hotel, make it dirty. So that is what literally an extra Ig does to your body. When it has finished tackling with that one allergen, then later the remaining Ig is left. They roam around your entire body like the goons who do after that political this one and roam around in the city, and that city will be contaminated. So this is what is happening with more of Ig. Now here, very important aspect I would like to tell you everyone is, earlier we used to always consider regarding only that asthma which is earlier in onset, not the late onset asthma. Then the phenotyping came into existence. We should never forget also ACO, AC. So now it is known to everyone that asthma COPD overlap. has to be taken care. There, other than LAMA and ICS, LAMA is also required. So such things we have to take into our account. And the genotype, clearly it is below 40, above 40, one sector. So below 40 is eosinophilic predominant, above 40 is neutrophilic predominant. And here there are two things: early eosinophilic or chronic inflammatory. In the first, I will first initially tell you about TH2. TH2, that is first thing, you have aspirin induced, exercise induced, and it is below 40 years, and there is an obstructive pattern there. You have early allergic or chronic eosinophilic pattern there. Coming to non-TH2, it is obesity related asthma, or it is smoker's asthma, or it is restrictive pattern asthma. There is obstructive, and it is above 40 years here now. So all these things differentiate the two asthma. When someone comes to you above the age of 40 years and tells you, and even his spirometry has got that 200 ml or 12% variation, then you have to think regarding after 40 years onset of asthma. So this is very important. So here you have to differentiate the phenotype. You can see that a CBC is very good enough to tell you whether it is neutrophilic predominant or eosinophilic predominant. And even the classical, what they tell, that AEC above 440 or the eosinophil count of CBC below 5 doesn't make any sense. Even if it is 250, 300 above, it should be considered as eosinophilic. So that is what I want to give a message to everyone here, that I will conclude at the very difficult to treat only, and I'll not go to severe asthma. So these are my points, and probably it looked like a presentation, but I had to tell you in a nutshell regarding the everything. Keerat.
Thank you, sir. Thank you. It's so wonderful seeing the teacher come alive in Dr. Krishna. And sir has so wonderfully and clearly elucidated that uncontrolled asthma can be difficult to control asthma, which sir elaborated, and it can be severe asthma. Severe asthma is what Dr. Rajadhar will be taking next year. Sir, I look forward to seeing you very soon in person at CCI Con Srinagar in June. And I look forward to meeting everybody over there, everybody who's watching us.
Thanks,
Welcome
Keerat.
to CCI Con. And
everybody who is here, come to CCI Con Srinagar.
And sir, we look forward to hearing more from you at CCI Con Srinagar in June.
Sure.
Thank you for joining us today.
Have a great day, everyone. Bye-bye. Thanks for fetching me. Thank you so much.
Thank you,
Bye-bye.
sir. Thank you
Bye.
for joining.
Bye.
Dr. J is with us. Dr. J?
Yes, I'm with you. Am I audible, ma'am?
You are perfectly audible. So,
Thank you, ma'am.
how would you like to? We talked about how to assess. Dr. Dhaval also talked about it. Dr. Krishna also wonderfully talked about what could be the comorbidities. Like they talked about that as well when someone is uncontrolled angina step 4 or 5. Dr. J, how do we address these comorbidities?
So, as likely Dr. Krishna sir told, it starts from head to toe. So, first and foremost, I remember it differently. Let us assess what we mean by comorbidities. So, when we are talking about asthma, the presence of bronchiectasis becomes a comorbidity. A presence of interstitial lung disease becomes a comorbidity, and presence of COPD becomes a comorbidity. So first, we have to look as a chest specialist on the chest front or on the chest part. If the patient is having hypermucus secretion, the patient may have bronchiectasis. In that case, the reason for uncontrolled asthma can be ABPA, and our therapy can be directed to that. If patient is a smoker, then this patient may have associated COPD, or may have interstitial lung disease, or may have certain other diseases too. So first we need to look on our own specialty. Now coming to another comorbidities, these are from our ENT and gastro colleagues. These are like chronic rhinosinusitis with nasal polyposis, without nasal polyposis. It can be sinusitis, it can be sleep apnea, or it can be gastroesophageal reflux disease. And then higher up, it goes to anxiety and depression. Now we have assessed all these comorbidities and we have to give appropriate treatment to that, and then it becomes controlled. Then it is, as sir told, it was difficult to treat asthma because with the modifiable treatment factors, now it is coming under control. The another features too, like if the patient is having still persistent breathlessness, we need to look for cardiac causes also. We need to rule out cardiac as well as pulmonary vasculature causes like pulmonary hypertension. Then there is obesity, which can cause decrease in the walk distance, or the sensation of breathlessness is not getting improved even after giving inhalers. Another comorbidity is osteoporosis, which is very high in our group. Low vitamin D is again, Gina is stressing on that. So we need to give vitamin D supplements on that. So like we need to assess patient as a whole, right? Starting from pulmonary comorbidities, that is existence of bronchiectasis, associated COPD and interstitial lung disease, to obstructive sleep apnea and obesity, to chronic rhinosinusitis with or without nasal polyposis and postnasal drip, to anxiety and depression, cardiac causes as well as neuromuscular causes. And with that, if we'll give targeted treatment, patient will definitely recover. Now, one of the most important point which I want to stress is 80% of cases, either it is improper technique or improper dose of the inhaler which has been given. It is very simple to give oral pill and patient can swallow. Well, the inhaler technique and prescription of inhaler demands certain expertise and experience. So every time, one of the most important message which I want to convey to CCI community is there are different ways to communicate and teach the patient inhaler technique. So whether it can be verbal, it can be a pamphlet, it can be demonstration on self, or it can be patient after education, patient is taking inhaler on his or her own. And I think the final one, that is patient demonstrates how he or she will take inhaler at home. It makes a huge difference. Not to forget that you have to check it again and again and again in every visit that they are taking. I will like to limit the inhaler which has been given only to one particular type. If the patient is comfortable with the present breath MDI, then it is so. I'll give all the molecules according in a present breath MDI. If patient is fit with the synchro breath, then it is so. Then pressurized MDI with spacer. I never give different types of inhalers. Like in same patient, I give PMDI with spacer, DPI, and nebulizer. So we have to limit ourselves to one particular inhaler therapy, which is best for the patient. It will also increase the compliance of a patient. Nowadays, what GINA 2024 has not talked yet is ultra-LABA ICS or U-LABA ICS, that are vilandrol fluticasone combinations, and how to deal with that. But this is, in my personal experience, it is having superior compliance. It's press and breathe MDI with spacer, and it works wonderfully according to my experience. So to summarize this, first and foremost, we need to identify the patient is having bronchiectasis, COPD or ILD, and we need to optimize accordingly. If the patient is having obesity, OSA, rhinosinusitis, and polyposis, we need to address that by constellation and GERD. We need to take ENT and gastro people in our loops. If anxiety and depression, we need to do some psychological counseling. And if there is a neuromuscular causes, musculoskeletal causes, we need to optimize that part too. And finally, cardiac comorbidities, we need to consult our cardiologist to help. So with that, I summarize the questions answered.
Thank you, Jay sir. Very well. You spoke very well. And it's so wonderful to have you on board. I believe you, I don't know if you are in a teaching institute, but I believe that your students would be extremely lucky to have you whenever you teach anyone.
Thank you, ma'am.
I would like to come to Dr. Dhaval. I believe you are in a...
add one point, Keerat. Okay,
yes, sir.
Whatever Jay has mentioned, as you rightly mentioned, brilliant presentation for the question. So one most important thing which I would like to add is not all smokers turn into COPD. There is a smoker component, okay, who are smokers, asthmatics who are continues to smoke. So this is one thing which we need to keep in our mind. As soon as asthma, so it's a tendency that we may forget about the smoking component, but it's not so. There may be few asthmatics who tend to smoke. They also become part of uncontrolled asthma because they are not stopping. They continue to smoke, and then similarly, the second-hand smoke also within the home and within the offices can continues to be act as a trigger. Over to you.
Sir, very well said. As a matter of fact, now that you're talking about it, what comes to my mind is also the concept of third hand smoke. People who enter places where somebody has smoked previously, even they are going to be triggered, as if there are asthma triggers in, they're noxious particles. And it is said that over the next, if say somebody smoked in an area and went out, if another person enters that area, those particles, they turn more toxic, more noxious at 6 hours, and even more noxious and toxic at 12 hours. I cannot imagine what a toxic chamber the smoking areas, the lounges in airports are. They must be, because it is not that somebody smoking there or not. It's that all that smoke is undergoing spontaneous degradation into more toxic components at 12 hours, at 18 hours. So it's just getting worse. And certainly, smoking is a very important part, and we should do our bit as pulmonologists to create awareness. Dr. Dhaval, coming to you.
Yeah.
Would you like to add anything at this point? Because you started with the GINA step 4, 5, and how we should assess. Dr. Jay Mehta added on how to further, how to manage it. Is there anything else you would like to add to this in terms of upscaling management? Anything?
In a lighter mood, Dr. Jay is my batchmate, and he used to teach us in our UG classes. So he's a very good teacher. You have rightly identified him.
Thank you.
Okay. Yeah. So almost everything is covered by Dr. Jay regarding the difficult to treat asthma. But the few points just I want to highlight is about the Dr. Jay and Dr. Vijay already mentioned about the how to optimize the medication with the help of the correction of the inhaler techniques, and it's a teach back method always, and every visit I'm more highlighting over that. Every visit you need to check how the patient is taking inhalers. We have already seen some patients taking DPI, that capsules, taking orally given for the inhaler and taking orally. So always check about the techniques, and some pharmacological add-on therapy we have to consider about, like Dr. Vijay has mentioned about the smoking cessation. Then you have to be physically active for your improvement in the lung exercise and everything. Healthy diet can be one of the important factors. Whenever the obesity comes as a comorbidity, we have to reduce the weight. Vaccination, one of the most important factors nowadays because of the post-COVID area, as well as the routine infection with the influenza and routine viruses. And whenever the possible, avoid the allergens. Though it is not helpful in the clinical benefits, but whenever possible, we have to avoid the allergens. And the most important is whenever you give a treatment or optimize your medication, always review after a few months, after maybe 3 or 4 few months. You have to review about the response of the treatment, whether the patient is having control of the symptoms in the form of frequency or maybe reliever using or nighttime symptoms, or in the last year or in a few months, how much exacerbation patient is having, or is there any side effects with the medication? What if sometimes we have to increase the doses of the ICS and all? So is there any side effects with that, or we have to always check about the adherence as well as the techniques every visit. Check for the lung function test, whether the FEV1 is particularly improving or not, along with the ratio, and ultimately the patient's satisfaction, and is there any concerns regarding whether the availability of the drugs or cost of the medications, or is there any other religious related problems patient is having. So we have to see about all these things whenever the patient is optimized with the medication and in the follow-up. And whether if patient is having uncontrolled symptoms, then even after this optimization of the medication and covering of the comorbidities, then we have to consider as a severe asthma, and the severe asthma management will be different, and it will be taken care in the next week. And whenever there is a control of the symptoms with this medication, we always go down or step down our ICS dose or something, whatever the optimized treatment we have given. And lastly, always take an expert opinion whenever you are in a confusion or something.
Why send the patient to you? Because I'm like, Dr. Dhaval is the expert.
I'm just talking about whoever are the listeners other than respiratory therapists.
Okay. So thank you, Dr. Dhaval. And we are having a lot of questions from the audience. I think we should start addressing them because there are so many questions. It will be difficult to keep up for me. Dr. Ajay Lanjewar from Maharashtra, from Nagpur, is remarking that LVF is also a very common comorbidity. Yes, Dr. Ajay. Cardiac asthma was mentioned in my presentation, and Dr. Jay specifically talked about having the assessing for cardiac status and getting the cardiologist on board if required. Next, Dr. S.K. Toke from Pune, Maharashtra is asking, what is the reason behind decrease in bronchodilator criteria? So, Dr. Toke, the ERS, it is mentioned in the 2024 advisory that they have reviewed, but they have not considered the advisory of ERS and ATS to decrease the bronchodilator criteria from 12% to 10%. And GINA 2024 as of now has not revised the criteria. They have reviewed the recommendations by European Respiratory Society and American Thoracic Society, but have not incorporated it. I believe somewhere the concern for conditions like PRISM, preserved ratio, decreased preserved ratio, decreased spirometry, yes. So they are a factor which is coming in, and that is the reason we are now also resorting to modalities like oscillometry. So it is very much an evolving criteria, evolving science. One thing I do feel somehow reassured is that GINA 2024, again, they have said that they are reviewing data. They are not quick to change things. They take their time. They take their sweet time. And to me, it makes a lot of sense. They have advised against, using only SABA since 2019. And now they are saying that we have reviewed enough patients, more than 40,000 cases they saw, and everything they mentioned. And now they are saying that we are clearly advising against it. So they take their sweet time to document things. And at the same time, the ATS are doing their job.
I would want to interrupt once. GINA takes time because GINA wants every doctor responsible to be able to treat it. The doctor may be situated at the best hospital at a national capital, or the doctor may be at the Andaman Island. Even they should be able to treat asthma. Maybe that is why every GINA update has something which can be practiced by everyone who is treating asthma.
Very well said, Dr. Atri. They are very inclusive. They are very inclusive. I mean, imagine someone could say, why are we talking about PEF when we are talking about spirometry? Now we should look at oscillometry, but they're saying no, a lot of physicians, a lot of specialists even do not have access to spirometry. So documenting how to use PEFR, diurnal variability, not just that, then using it as a post bronchodilator, those criteria they are setting and assessing and reassessing for us. I do have a lot of faith in Gina Advisory, and I'm happy to be a part of this webinar so we can talk about it. Let me have the next question. This is open to the house. Anyone who is comfortable, please let's take these questions. Dr. Surendranath Banerjee from Niyamatpur, West Bengal is asking, when serum IgE level is quite high despite normal chest X-ray in case of even stable asthma, how do you suggest to a patient, like what do you suggest? I think, Dr. Surendra, you need to evaluate the cause for raised IgE. And, the X-ray may be normal, but maybe this patient has chronic sensitivity or chronic sensitization
Yeah,
to
I would want
any
to have a
allergy.
different take on this. Sometimes blood IgE may not correlate with respiratory allergy. Somewhere over here, Pheno has come up as a more sensitive tool for airway allergy or breathe allergy. Like in our country, even parasitosis can cause increased IgE. Lots of skin allergy, lots of sinonasal allergy can cause increased IgE. But Pheno, exhaled breath nitric oxide, more better marker.
Very well said. So we need
Another
to
important
evaluate.
thing, Kirat, just I
Yes.
want to add another important point here. If the serum IgA level is high, okay, first of all, what is when the patient is having stable asthma and then there is no other issues, there is no need to look at this entity when the things are under control. Okay, and when the X-ray is normal, we should not worry about it. But if the X-ray starts showing any opacities like ABPA, then probably we should pitch in and then evaluate for ABPA as per the ABPA criteria. Otherwise, okay, we should not worry about IG alone, as you and then Atri rightly said.
I would like to share an experience here. I had a patient with asthma, and this patient turned out to be HIV positive. And this patient actually had strongyloids. So IgE was very high, but ABPA workup was negative. So I was like, why is it still on the higher side? So it was the parasite causing the high IG. So we have to look up for a patient. Say if you have high eosinophils, you look at what could be the other differential for eosinophilia. It's not just necessarily allergic asthma. It could be EGPA. It could be, you need to look at the other differential as well and work up the patient. Next, I would like to take question. This is again by Dr. S.K. Toke from Maharashtra, Pune. Why the term ACOS has been removed? Any remarks on this, panelists?
My feeling here is okay. ACOS is not a disease alone; it's a overlap syndrome. Okay, so majority of times what happens is I can say among COPD patients, as per the literature, close to around 20-25% of patients they tend to have asthma as overlap. And then among the asthma patients, if poorly managed, once the airway remodeling has occurred, they land into COPD component. Approximately, we do see approximately 15 to 20% of such cases in our practice. So this is what. So ACOS as a diagnosis is not there. It's a two things overlap that we need to, I think, manage as per the both the entities. As a disease, it is not there. That's what is my understanding. Over to others.
I think when we have a patient,
The disease, sir, I'd like to give one more input. Before around 10 years or so, the SEOS has, we would be seeing in GINA guidelines, there were there was a big, this table where we need to just tick everything. One is asthma, one is COPD. That table is not in the GINA guidelines now, but the term has now appearing in GOLD guidelines, not in the GINA guidelines, as a COPD-A. So now they have phenotyped the COPDs like COPD-S, that is smoking related COPD, and then COPD-A, which is asthma related COPD. So I think it has transformed from one guideline to another guideline, and now we are seeing in GOLD. But I think more or less the spirit of the term remains the same. It is asthma COPD overlap, as you rightly said, sir.
so we have in the definition itself that the variable airway, uh, you know, reactivity or the variable airway response
Limitation.
limitation, it can become permanent. So this line, the sentence is a part of the definition itself. So what happens when it is there's limitation, it becomes permanent. And I think ACOS is something we used to label patients who would come to us for the very first time with acute exacerbation. We can't do a PFT, we don't know, was it a uncontrolled asthma, was it an uncontrolled COPD. So this was a common term which was used, but it really didn't help much in terms of management. It was such patients would be in the ICU. So next question I would like to take from.
Oh, before that, Dr. Keerat, the first question was asked by Dr. Anand from Tamil Nadu, Tiruvannamalai. So the very beginning, if you see the questions, okay, yes. Because we must answer the first shooter question. So whether Vilantrol plus fluticasone combination can be used as a maintenance and reliever therapy. My dear friend, Dr. Anand, thank you for taking part enthusiastically in our webinar. So my take here is, since Vilantrol and fluticasone both are long-acting, and Vilantrol is not approved for maintenance and reliever therapy, and you have to combine as a reliever, anti-inflammatory reliever, that is SABA plus inhaled corticosteroids separately, not to recommend Vilantrol plus fluticasone to use as a reliever therapy. Over to you, Keerat. And then Sujata Sarda from Maharashtra. So, role of allergy testing and immunotherapy at which stage? Over to Jay or Keerat itself.
So, allergy testing. First of all, I was going to come back to Dr. Anand from Tiruvannamalai. It was his first question that we received. It's just that there were so many questions. It got a little overshot. So Dr. Sujata from Latur is asking the role of allergy test and immunotherapy at which stage. One thing is, Dr. Sujata, one absolute or one contraindication for allergy testing, skin prick allergy testing, which is the gold standard, is that if the FEV1 is less than 60%. So such a patients, they can have an acute asthma attack, they can have an exacerbation. So we do not do allergy testing in such patients unless it is controlled. If you're able to control it on medication, then you can use it. So this would be my input on this. And immunotherapy at which stage? Again, immunotherapy at that stage only where you can do an skin prick allergy test and identify the allergen, and only from in those cases you can go in for immunotherapy.
Yes, completely agree.
Any inputs from the panel on this?
Yes, ma'am. So in nutshell, skin prick testing and allergen immunotherapy are at stage 1 and 2. And step 1 and 2 of the GINA table, and biologicals are at step 5. So this is how we tell many of the patients come to us when to do. Just before stopping or doing SOS inhalers, we do skin prick test so that we can get an idea whether they are fit for subcutaneous immunotherapy against dust mites or not. So that we can use this GINA guidelines also has talked a lot about remission. So we can induce long-term remission of asthma. We should not use the word cure. We should use word remission. And this is actually possible with the help of SCIT, but it's in the step 1 and 2 of the GINA, the spectrum.
Thank you, sir. You're right. I would like to take the next question now. This is from Dr. Vikas Shukla from Mumbai, Maharashtra. Dr. Vikas asks that how do you label patient as allergy by IgE test if patient's reports are normal and patient is currently suffering from cold? The patient is currently suffering from cold. It could be a viral, it could be a URTI. I don't think that's the right time you want to assess a patient for allergy.
Other important thing, Keerat, he said very clearly, recurrently suffering from cold. So,
right.
my dear Vikas, okay, Dr. Vikas, so please make sure that there is some entity called, okay, apart from recurrent sinusitis and infections, okay, we have an entity called vasomotor rhinitis, sometimes which is resistant to treatment with inhaled corticosteroids and inhaled antihistamine, is What we often in our practice we miss is vasomotor component. We have to address that vasomotor component as well. Go to next question in the interest of time.
So, next question from Dr. Saikat Bhaumik, Tripura, Agartala. He's asking, or she's asking, so many guidelines: GINA, ERS, BTS, ATS. Which one does the panel follow in day-to-day practice? I think if I can speak for myself, I mean, there are also nice guidelines. The National Institute of Central, Excellence. I follow GINA. For asthma, I follow GINA. I read the other guidelines. I see what they have to say. But GINA guidelines for me. For asthma, I look at ERS guidelines for intervention pulmonology. I think I've read most of BTS for for thoracoscopy related guidelines. So I've followed ATS for the non-tubercular mycobacteria related guidelines. So we all have we know what guideline to follow where. So this would be my take on this. Open to the panel.
Ma'am, this is very important question from the front of litigation. So that's why we need to follow. We need to follow which is followed by many people. So GINA is most commonly followed guideline, and that's why I think this is where you need to take a bench. That this is a benchmark guideline, GINA in asthma. If you are treating COPD, then it's gold, and then for HP and everyone IPF, there are different statements. So this is very important. You need to follow what everyone else is following. So it will help you if somebody asks why you give this, why you give that. You have at least some backup that we are following this, which is followed by everyone else also.
Dr. Atri?
Go with GINA. Please go with GINA. What they are doing, most important thing is all inclusiveness. Just like Chest Council of India, all inclusiveness. It doesn't matter what background you are after your MBBS. If you love chest medicine, Chest Council of India welcomes you with open arms. We are conducting our physical annual meeting, the first large meeting after COVID on 8th and 9th June at Srinagar. So it's a request to all the members out there. We are a big digital family. Let us meet in person for our thirst of ever-ending pulmonary knowledge.
I can't wait to meet everybody and see everybody at Srinagar at CCI Con. So thank you, Dr. Atri. And I'll quickly take the next question. The next question is from Dr. S. Jayaraman, Tamil Nadu, Chennai. Dr. Jayaraman always has interesting questions. He's asking, what is the stand on bronchial thermoplasty in non-type 2 severe asthma? I have a very good answer. Dr. Rajadhar will take this question next week because we are talking difficult to treat asthma. And only, I think, a single institute is doing thermoplasty.
Can I add here?
This is no longer, I think it is no longer practiced.
Exactly. The thermoplasty is no longer practiced across the globe because the catheters that they are producing is by the company is now no longer financially viable, and then they have withdrawn from the market. And bronchial thermoplasty, as of now, in management of either non-TH2 or TH2 asthma, it is obsolete.
Dr. Jayaraman, do not buy a new thermoplasty equipment. If you are planning
they're not giving it as well. They're not selling. That's not in the market at all. Right.
We have two top IP people here, Dr. Chennam and Dr. Mehta with us. So I'm so glad.
Yes.
Thank you.
The first Indian patient who underwent thermoplasty was from Apollo. Okay. Apollo Jubilee Hills. Okay.
Your center. Wow, sir. Congratulations.
No, not at our center. I want to make it clear that patient was referred to US for getting the thermoplasty done, got done, and then, but at the end, it was showing no improvement, no significant improvement. Right. Please go ahead.
Dr. Jayaraman, do not put money on thermoplasty. Dr. Chennam is warning again. Next, Dr. Ajay Lanjewar from Nagpur, Maharashtra is asking, how common is pulmonologists treating children, particularly when parent-child specialty refer a child below 12 years of age with uncontrolled asthma? I would like to have this open to the bench, and I think
Jay, with your Jay and Dhaval, okay, I would love to take because at least weekly one or two kids being referred for us for managing pediatric asthma, very difficult to control or uncontrolled kind of thing. So the most important thing which we need to address here is so concomitant sinusitis, presence of adenotonsillitis, presence of sleep apnea, presence of GERD. So these are all the various things. Children's, particularly in this season, we cannot control them from eating the cold beverages and ice creams. These are the common things which I see as a common things, comorbids, which we need to address, which we need to keep it in our mind while treating uncontrolled asthma in children. But we should all, because pediatricians, they are comfortable in treating a stable asthma, but not uncontrolled asthma. Over to Keerat.
Thank you, sir. Dr.
One more
Dhaval,
point.
Dr. Utkarsh, please,
Yeah.
yes, please come in.
And one of the most important factors for the uncontrolled is the choice of inhaler devices for the children, because patient less than 5 years or 6 years old may not be able to use that inhalers properly. We have to use that spacer in between or nebulization. So inhaler device choice is also one of the important factors.
Dr. Utkarsh, would you like to add anything to this?
No, ma'am.
So one thing is that formoterol we can use in children above 6 years of age.
No.
Above 12 years of age.
No, not approved.
Not approved. Above 12 years of age we can use. Okay. So next we have a question from Dr. Saikat Bhaumik, Tripura, Agartala. Developed world has an opinion that in developing country, due to parasite infection, our patients have higher IgE levels. According to panel, how much high IgE is significant in Indian context? So, according to Dr. Kathuria, Master of Allergy Training, sir said that 500 should be the cutoff. 250 is generally the written cutoff in our reports, but he said double of that, even up to 750, and you have to clinically correlate. Over to the masters on board for their remarks.
Absolutely fair enough. Yeah.
Ma'am, the serum total, first and foremost, when we use word Ig, we need to differentiate between serum total Ig and allergen specific Ig. Many times they are written specific Ig. Specific Igs have different cutoff values. Now coming to serum total Ig, now Dr. Saikat Bhaumik, I will tell that you are in context of what we need to evaluate the serum total Ig level. So first and foremost, for diagnosis of allergy, serum total Ig has no value. If you want to diagnose a patient with allergy, you always have to do allergen skin prick test. If serum total Ig is more than 1000, more than 1500, then it raises suspicion of ABPA. So that's where role of serum total Ig comes in uncontrolled or difficult to treat asthma. Whether this is more than 1500 or so, or we are not missing out anything else. So just because somebody's serum total Ig is on the higher side, having told that there are different cutoffs for allergen specific Ig, which we do with the CAP method. Ma'am, am I audible, ma'am?
Yes, please go on.
Ma'am, am I audible?
Yes,
So
please go on.
With that, there are different like Aspergillus fumigatus specific Ig has certain cutoff, and Alternaria specific Ig has certain cutoff. That cutoff is 0.35, 0.0 to 0.35. So we have to be very specific what we are going to do with this serum total Ig data. If somebody is having 700 or 800 total Ig, doesn't mean the patient is having asthma. We need to see clinically. And if you want, we can do allergen specific Ig or we can do allergen skin test to find out what the allergens are. So that is my take on Ig level.
So very well said, sir. I think even up to 1000, I think that's what we look for in terms of ABPA. But here's one thing I want to add here. We are talking about asthma. This is a discussion on difficult to treat asthma. But when you're thinking IgE, and we're getting so many questions on IgE from our audience, please look at other causes for raised IgE. It could be increased in PAN, in Kawasaki disease. It could be viscid aldrich. It could be gammopathy. It could be nematode, trematode, hydatid. Hydatid would also have raised IgE. Please look at all these causes for increased IgE. Please run that differential and work up the patient accordingly. And in general, if it is up to 1000 Ig, I would not be that alarmed. I would like to reassure the patient. Rest, it also, we have to always clinically correlate how patient is symptomatic, specific Igs are positive or not, whether there is an indication for skin prick allergy testing or not, so on and so forth. Dr. S. Jayaraman from Tamil Nadu, Chennai. Sir is very kind, and sir is congratulating Dr. Krishna on his keynote address in today's webinar, and sir is congratulating the panelists, awesome superstar panelists, Dr. Atri, Dr. Vijay, Dr. Dhaval, Dr. Utkarsh, and Dr. J. And so Dr. Jayaraman is sending our lovely panelists his compliments. Next, Dr. Sekar Bhaumik. He's Dr. Sekar, don't apologize for your question. Please feel free to ask as many questions as you like. He's saying how much absolute eosinophil count is significant. Dr. Mehta, what do you think about this?
So, ma'am, according to the severe asthma guidelines, more than 300 is one which they feel comfortable as having eosinophilic or diagnosis of eosinophilic asthma. So it can be more, like we can go up to, if we are more confident, if it is more than 500. But according to the guidelines, it's more than 300 where they diagnose at eosinophilic asthma. And why it is very important? Because we need to choose biologicals. I think Dr. Rajadhar in next session will be able to guide us more on that part, what the clinical relevance of eosinophilic as well as atopic asthma and how to choose biologicals on that.
Certainly, Dr. Rajadhar will be taking this next week. Dr. Kamlesh Kumar Sharma from Rajasthan, Jaipur is saying he's sharing his agony that he's suffering from serious asthma, biological already taken, no improvement. Please guide. Dr. Kamlesh, first of all, our empathy with you on your suffering, and because you are suffering from serious asthma, no one can understand the plight better than you. We are all trying to help our patients, but this really is difficult from what I understand. You please feel free. You are a part of the CCI family. Please feel free to contact any of the tops. We have all the stalwarts on board. Please feel free to contact anyone, any top specialist in the country that you want to connect. Please reach out to them directly. If you have any problem, Dr. Krishna is most benevolent. He helps everybody. If you want to talk to Dr. Chennam, Dr. Atri, or you want to talk to Dr. Rajadhar, who will be online next board, you want to consult anyone, please feel free to talk, because based on this little information, no one can give you any serious advice. So you need to directly talk to a specialist on board. So here are some suggestions from Dr. Krishna sir. He says that when he began his practice, there were no pediatric pulmonologists, and they had to treat all kinds of pediatric patients. And I think a lot of times the pediatrician sends the patients to us when the family is not happy with the treatment. And
yeah, I would want to extrapolate here that often I get parents whom I am treating with asthma. They ask me, can they consult their child to me also, who is also having similar symptoms? I would appeal to all pulmonologists watching this webinar. Don't differentiate pediatric asthma, treat it as asthma. If a child has come to you, you're thinking of asthma, please go as per the guidelines, please treat it. Don't differentiate pediatric asthma. Our pediatricians are so busy. They need to take care of vaccinations. They need to take care of growth charts. They need to take care of, let's say, convulsions. Then lots of infections in children. And if a parent is bringing the child to you, please take care of that asthma.
How often would a pediatrician advise a child for oscillometry? So this is the gap in information. This is the gap in knowledge. And where if someone is coming to a pulmonologist, we cannot say, oh, you may not get the chance to shrug it off and say, oh, I'm not a pediatrician. Please go to the pediatrician. The pediatrician may have sent the patient to you. So yes, we have to read. And I really appreciate that Gina has a specific guideline on children's asthma. For Gina 2024, that is still awaited, that pocketbook, but it will come out, and I find it very helpful. And I think we should make up our mind that, we have to deal with pediatric asthma. We cannot shrug it off. So Dr. Krishna, in his own style, says there are GINA guidelines, there are GOLD guidelines, there are no ACOLD guidelines. As in, that's why no ACOS, no ACOLD guidelines. Guidelines they are just a document. Ultimately, your decision you have to make as per your experience and learning from whatever you are, gaining. Next question from Dr. Surendranath Banerjee, West Bengal, Nematpur. Which phenotype of asthma should use vilantrol and fluticasone? And Dr. Dhaval, Dr. Chennam, who would like to come on this question?
Oh, to my best of knowledge, I haven't used much of this combination in asthma patients, but very rarely when a patient, because now the fluticasone is available, or bilantrol fluticasone combination is available with a dosage of 200 microgram of fluticasone as well. Probably we may end up in using in very stable asthma to increase the compliance of the patient, or those who prefer to use once a day daily therapy, because ultralaba plus fluticasone, which is also a long-acting one, so may be suitable. But again, if you want me to look at the gross evidence or very good evidence for this kind of recommendation in asthma, it is not there. Over to Dhaval. Dhaval wants to say something.
Yes, sir, rightly said. It is mainly used for the stable asthma patient, where we use as a controller, and whenever the patient is having problem with the adherence or something, where only once a day treatment we want to give, then it is very much important as a vilantrol, which is ultra lama.
So taking this up, this is again open to the panel. What is your experience with single inhaler, triple therapy, Dr. Chennam? Is it feasible in asthma? What is your experience?
In the interest of time, single inhaler triple therapy, first of all, okay, let me add my experience. Okay, we started using triple therapy in asthma more than a decade back. Though the guidelines, the robust evidence exists now, let me share my experience first, then followed by evidence. So in terms of experience, there used to be an inhaler which consists of formoterol, tiotropium, and along with cyclisonide as an inhaled corticosteroid. So this we used to use in case of patients who were not stabilized with LABA plus ICS. So these dates I can say from probably 2011 onwards I was using. It's an absolutely brilliant one to use. But to coming to evidence, so there is a meta-analysis which consists of probably, I think, 5 randomized controlled trials, like the trigger trial, okay, iridium trial, argon trial, captain trial, so many. Okay, together, what it says is single inhaled triple therapy, okay, with high dose of inhaled corticosteroids when compared to low dose inhaled corticosteroids, as I was mentioning in the earlier question, that is fluticasone containing 100 microgram versus fluticasone containing 200 microgram. If the 200 microgram one is very, very high effective in terms of improving the symptoms, and in terms of improving the FEV1, in terms of decreasing the number of exacerbations. And SIT, okay, has similar effect. The conclusions of this meta-analysis was SIT has a similar effect as MART. Okay, maintenance, that means LABA plus ICS inhaler. And in terms of robust clinical evidence, I personally, I don't have it. But again, the evidence from this meta-analysis says that SIT can be used comfortably as a with high dose corticosteroids like fluticasone instead of 100 microgram, 200 microgram can be used in the practice.
This could actually be a game changer in the future if they're equating SIT with MART, because MART is currently the protocol of choice for most specialists. So, what is, I think, I want to ask everybody this last question, that how do you manage allergies? Your one remark in allergy management in cases of asthma. I'll start with Dr. Atri.
Please try to identify and respect the triggers. If there is a trigger, try to avoid it. If the trigger is unavoidable, keep some rescue medicines nearby.
Dr. Utkarsh. Please unmute.
Same as Dr. Atri said, trigger should be avoided. Second, any pollution should be, patient should avoid pollutions also. Trigger, and second, that's all, ma'am.
Thank you. Dr. Dhaval.
You have to educate the family and the friends regarding regarding about your allergies, so that at least, and what medication you are taking or you have, so at least whenever there is an emergency they can help you out.
Thank you. Dr. Mehta.
Ma'am, it is very easy in pediatric population to find allergy because it's mostly food allergy, the big six. But when it comes to adult population, which we routinely deal with, it becomes very difficult to pinpoint whether this is dust mite, whether pollen, whether fungus, whether insects, cockroach, anywhere. So what we do, we find out the allergens with a mix of blood test as well as allergen skin test. And once we find out treatable allergies, like which are potential targets for subcutaneous or sublingual immune therapy, we try to maintain and we document the remission. And we give it for a long time, and that's how we do it. So we always, in one sentence, we tell them the allergies have three fundamental principles. First is avoidance, second is pharmacotherapy, and third is immunotherapy. And then everybody is having different kinds of allergies, even though twin brothers don't have similar types of, that's why this is an heterogeneous disease. So we identify the potential, we help patients identifying potential culprits, avoidance, pharmacotherapy, immunotherapy, this is our three pillars. So with that, we induce remission.
Thank you, sir. Is it possible to treat wheat allergy with allergen immunotherapy?
Ma'am, we usually do dust mite immune therapy. When it comes to pollen, like you told about wheat pollen, I think I heard right? Is it a wheat pollen, ma'am?
No, wheat food allergy.
Food, for food, it's only avoidance. There are some oral, definitely there are some oral challenges which we develop slowly, but I always tell them, because of the risk of anaphylaxis, we cannot produce it in-house. So we always tell to avoid food allergens as far as possible, ma'am.
Dr. Chennam, sir, your final.
I just want to read what Dr. Krishna has written the comments here. Strict use of anti-pollution mask with filter, not COVID mask. Okay, where triggering factors or allergens are present in the given individual. And when the housewives or chefs, if they are suffering from asthma, it is mandatory to use masks while cooking, sweeping, and cleaning dust. This is the comments from Jaint Krishna. Okay. I don't want to add anything. I agree with all the panel.
Thank you so much. Thank you, dear panelists, for such a wonderful association in today's webinar. It was like a medley where Dr. Krishna came and, and everybody, we were in the same tune, and it was wonderful discussion. I thoroughly enjoyed it. And thank you for joining in today. And I want to thank dear audience, our dearest audience who has been with us till the end, still asking questions. And we have hopefully answered to everybody's heart's content. Dr. Sakat Bhaumik Agartala Tripura is requesting to conduct a webinar on pediatric asthma and its management. Dr. Bhaumik, we will forward your request to Dr. Krishna. Thank you so much, everyone.
I just want to add one thing. As my professors, pulmonology professors, Ravindra Babu sir and Prem Kumar sir, as they mentioned very clearly while managing asthma, most important thing in managing any patient or any asthmatic patient for that matter is first do no harm. Okay, so be clear and learn about, what are these side effects of the medications, learn about pharmacology, pathophysiology appropriately. And this makes your job of deciding which treatment that your patient would be requiring at the given point of time, and spend that extra 1 minute to educate the inhaler to the patient by yourself. Over to you.
Thank you, sir. We are exceeding time, but it would be, I cannot disrespect the audience. I have to take the questions which are still pouring in. Let us quickly try to address our dear audience's question. Dr. Kamlesh Kumar is saying no improvement. Dr. Kamlesh, as I said, please directly contact any consultant that you are comfortable with from CCI family. You are a part of this family, and whatever is best, top people in the country are here to help you.
It looks like, if I may add comment to Mr. Kamlesh, Kamlesh may not be our CCI life member. He looks like a patient who logged in by seeing the our webinar. That if my understanding goes correctly, so probably please meet our expert pulmonologists in the CCI. They will guide you. And I really empathize with you. There were 20 times of exacerbation in the past 2 years. That is so pathetic. We're very sorry. We need to address you very holistically. We will be happy to take you, either me, Jay, Keerat, Atri, anyone, or Rajabai, Krishna, anyone. Please talk to take a consultation and then meet us. We'll be more than happy to control your, first of all, we will understand systematically and then suggest accordingly.
Dr. Kamlesh ji, I think you are, because it's mentioning that you are from Jaipur, Rajasthan. You can also meet Dr. Shivani Swami at Jaipur. She's an excellent pulmonologist, and I'm sure she will do whatever is possible at her end. And she is in contact with us. She's an essential part of CCI, and you will get the best of services which are possible at her end. Please contact Dr. Shivani Swami. You can search online.
No, works with NH.
She works with
NH? She works with NH. Narayan Hridayalaya.
He works with Narayan Hridayalaya. Okay, thank you. Thank you for adding that, Dr. Chennam. So, Dr. Ajay Lanjewar from Maharashtra, Nagpur is saying that fluticasone 50 microgram was used in children as well as chromal 5, disodium chromoglycate. Why both are not available now?
Very, very difficult to answer. I still remember few of my seniors, they use disodium chromoglycolate. I believe it is still available. I don't have any comments from my end for fluticasone 50 microgram. I still see prescriptions from few of the senior pulmonologists. They do write chromal 5.
Any comments from anyone else on the panel? I have not used disodium chromoglycate. I've read about it, but it's just not in part of the modern plan.
It's a massive
read about it.
Right.
For example,
it's available in Hyderabad. I'm sure.
Is it good experience with
Many
that?
patients from Africa.
I have never written myself, but I have seen a few of my seniors writing it.
Many patients from Africa come with this, sir. Many patients from Africa, we have overseas department. Many patients from Africa come with disodium chromoglycate, but we always tell them because we have superior molecules now. That's why this is no longer available in India.
Thank you, Dr. Mehta. So that's it. Dr. Surendranath sends his compliments to the panelists for a beautiful panel discussion. Thank you, Dr. Surendra. Dr. Surendra from West Bengal, Niyamath. Thank you so much, everyone. Thank you, panelists, for we have exceeded our time, but you have all been so patiently been with us, as has been our audience who has been with us till the end and still sending in questions. But we have not missed any question. If something is missed out in this, long list, and I apologize right now because we can never mean any sort of disrespect to our what should I say?
Kirat,
Param
one
Pujya
second, one
audience.
second.
To our,
Kirat,
yes, sir.
Terbutaline sulfate was there earlier. Terbutaline sulfate was there earlier. As
Yes.
it was used as an inhaler. It was before the salbutamol and formoterol, salmeterol. So it was there, but it is no longer used now. So is the case of the previous question. There are better molecules now, hence it is not used. And India is the only country which has got the hugest availability of all the combinations in the entire world possible with every drug in respiratory medicine and other field also. And we are very lucky to stay in India for the very same reason. Just you go across anywhere, you probably understand that this is not the case with any other country. You have easiest option, you have the cheapest consultation, you have the easiest available to doctor, but you have the highest assault to the doctor also. So it goes like that. So actually speaking, we are highly vast today in our combinations. We are way beyond any other country in the entire world regarding the combinations in respiratory. But however, I tell you that those which are still practiced probably in other countries are no more practiced here for the reason that we have evolved ourselves. That's it.
Thank you, Krishna, sir. Dr. Krishna is very humble. We are blessed to have his wisdom. I think what Dr. Krishna doesn't talk about much is that he trained in England in pulmonology. And that is why he's able to give us that comparison. But he loves India so much, wearing a flag of India t-shirt. I mean, I'm just joking, sir. I know it was your alumni t-shirt. But thank you for all the wisdom that you bring to us. Thank you, sir. Dr. S.K. Toke from Maharashtra, Pune is also sending his compliments to the panelists. Thank you, dearest panelists. Thank you, Krishna sir, for being with us today and always. And hope to see everybody at CCI Con, Srinagar, 8th and 9th June. I have booked my tickets and I'm ready to see Kashmir. I've never seen Kashmir and I hope to see you all there as well.
Thank you, ma'am.
Thank you. Thank you, ma'am.
Thank you, ma'am.
Thank you,
Thank you for the
everyone.
wonderful moderation, ma'am. Thank you so much.
Vijay, thank you. I really learned a lot from all of you, Dr. J, Dr. Utkarsh. As usual, Atri in his own style, unique style, versatile style. Okay, Dhaval, very, very great meeting you.
Thank you, sir.
We must thank you, our technical team, Vinod and Vijay, for always being so supportive in conducting the webinars consistently for the past 4+ years. Thank you. Thank you all.
Thank you.
Thank you so much, sir. Thank you so much, sir.